Hello, sir, I'm audible. Hello.
Hello. Yeah, Vikramji, you're audible.
Okay, thank you, ma'am. So, good morning, everyone. I'm Vikram Dagar from Swasth Derma Labs, and joining me today are Dr. Deepak Jakhad of Dermosphere Clinic and Dr. Amandeep Saluja from Indira Gandhi Hospital, Dwarka. So, about our lab, we specializes in providing customized dermatological testing and packages developed in collaboration with doctors. We offer superior skin biopsy reports and comprehensive diagnostic packages for skin, hair, and nails. So, today our discussion will focus on the lab test necessary for diagnosing hair loss in India. Uh, Now, I'm inviting Dr. Deepak Jakhar to proceed further.
बस भैया बस 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 आपको पीछे ही लेना पड़ेगा। ले लो पीछे, आगे से रास्ता नहीं है। मुझे भी पीछे ही जाना।
Yeah, thank you, Vikram. So, for the kind introduction, can you just stop sharing your screen?
अरे मेरे में नहीं दिख रहा।
Vikram, can you stop sharing your screen, please? Yeah, thank you. So, thank you for the kind introduction. Today, we are going to discuss about the importance of doing blood test and the various lab tests for the diagnosis and management of the various hair loss disorders that we see in our OPD. To take us further, we have a very young dermatologist with us who is going to take us through the various lab tests that are required for the diagnosis as well as the management of hair loss. We have Dr. Amandeep Saluja, who is working as a senior resident in Indira Gandhi Hospital, Dwarka. And she has got a good amount of experience in dealing with patients of hair loss. And we would love to hear how she is doing and managing the various lab tests that are required for the diagnosis of hair loss. So I now invite Dr. Amandeep Saluja to proceed with the presentation.
Thank you for the introduction, sir. Good morning, everyone. I'll just share my slides so we can start with the presentation. Right, so the topic for today's webinar is lab test in hair loss, detangling the mystery. Hair loss is also known as alopecia, and it is one of the most major problems that we encountered in our day-to-day OPD, which are seen both in men and in women, which is a major source of distress. There are various causes of alopecia, including both scarring alopecia and non-scarring alopecia, patent hair loss, telogen effluvium, drug-induced hair loss, hair shaft disorders, and congenital. Hence, a systemic approach has to be taken by the physician, including history taking, clinical examination, laboratory evaluations, and specialized tests in diagnosing the cause of alopecia. Now, lab tests here become an essential tool in diagnosing the underlying cause of alopecia, helping the healthcare provider or the dermatologist to make an accurate diagnosis and guide an appropriate treatment. So in today's discussion, we'll be talking about the common causes of alopecia, androgenetic alopecia being one of them. Androgenetic alopecia is seen both in men and in women. In men, we call it the male pattern baldness, and in females, we call it the female pattern baldness or female pattern hair loss. It is the gradual thinning of hair, typically starting at the temples and crown for men, with a complaint of receding hairline, and diffuse thinning along the part for women with scalp visibility. Lab tests and approach in such cases are focused on mainly iron profile and the hormonal levels, that is the testosterone, impacted by hormonal fluctuations, menopausal impact in women, and genetic testing in men. Talking about the iron profile, ferritin is the main iron binding protein in non-erythroid cells, reflecting total body iron stores. It decreases from a very early stage of iron deficiency as iron reserves go down. Because only iron deficiency can cause very low serum ferritin concentration becomes a very specific marker for iron deficiency. Various studies have been conducted that iron deficiency can be a certain factor of developing or worsening female pattern hair loss, especially in premenopausal female patients, but its role in male pattern hair loss is hard to conclude. However, the screening for iron deficiency as the first line evaluation of hair loss in even male patients might be worthwhile in our clinical practice. Coming to the role of testosterone, in female pattern hair loss, testosterone plays an important role by contributing to hair thinning when levels are elevated, primarily through its conversion to DHT, which is dihydrotestosterone, which can shrink the hair follicles and lead to a reduced hair growth. Androgen sensitivity, while women produce much lower levels of testosterone compared to men, genetic predisposition can make certain hair follicles highly sensitive to even a small amount of androgen, causing them to miniaturize and produce thinning of hair. Now, why is the conversion to DHT an important point here? It is because DHT is considered the primary androgen responsible for hair loss in both men and women, causing miniaturization and thinning of hair. And testosterone is converted to DHT by the enzyme called as 5-alpha reductase. And that is where finasteride as a treatment plays a role. Hormonal fluctuations are seen in women who are suffering from PCOS, which can also lead to an elevated androgen level, including testosterone, which may contribute to female pattern hair loss. Now, during menopause, estrogen levels decline and the relative proportion of androgen like testosterone can increase. This potentially leads to hair loss again. Therefore, along with the iron studies and other nutritional deficiencies, hormonal profile tests, including testosterone or DHEAS, should be advised. Lastly, talking about the genetic testing, which is not done in our routine practice. So genetic factors modify the magnitude of hair follicle responsible for circulating androgens. Those with strong predisposition go bald in the teenage years only, while the ones who have weak predisposition may not go bald even in their late 60s or 70s. So basically, the baldness risk increases with number of affected family members, and it is more consistent with the polygenic inheritance. Another common entity that we come across in our everyday practice is telogen effluvium. It is the sudden, diffuse shedding of hair, often triggered by stress, illness, medication, or hormonal changes. Hair loss typically occurs 2 to 3 months after the triggering event. Lab tests done in this condition are CBC, ferritin levels, thyroid function test, and vitamin levels. Complete blood count. It is useful to identify anemia, which is a contributing factor to telogen effluvium. A low hemoglobin level may indicate iron deficiency. Now, iron deficiency causes impaired oxygen delivery to the hair follicles, and it is important for cellular function and the synthesis of DNA, which are critical for hair follicle health. Without enough iron, the production of proteins and enzymes that support hair growth may be impaired. Ferritin is a marker of iron stores. Low ferritin means low availability of iron seen in iron deficiency, which is a cause of telogen effluvium. The likely mechanism for the possible effect of iron on hair growth stems from its requirement as a metabolic cofactor for ribonucleotide reductase, which is a rate-limiting enzyme in DNA synthesis. The depletion of iron could prevent proper functioning of this enzyme, which may result in inhibition of proliferation. Now, the inhibition of other iron-dependent enzymes such as steroyl coenzyme A desaturase which when mutated causes hair loss in human hair follicle, contributing to the hair loss. Next, we come up to thyroid function test. So in human scalp hair follicles, thyroid hormone signaling can extend the anagen phase of hair growth, modify the expression of specific keratins, promote the proliferation of hair matrix cells, and delay the onset of programmed cell death, which may lead to follicle regression. While thyroid hormones have limited influence on the creation of a new hair shaft, T3 and T4 are responsible for increasing energy production in the mitochondria of human hair follicles. Now, here both hypo and hyperthyroidism can cause hair fall. Hypothyroidism is thought to impede the division of epidermal and skin appendage cells, leading to catagen phase and a delay in telogen hair re-entry into the anagen phase. And hyperthyroidism, on the other hand, stimulates the production of reactive oxygen species in untreated individuals, resulting in oxidative damage, peroxidization of biomembrane lipids, and increased free radical formation in the mitochondria. Lastly, talking about the vitamins. So vitamin D receptor appears to play an important role in hair follicle cycling by regulating the growth cycle, inducing the development of mature anagen hair, and enabling stem cells in the bulge to replicate. The vitamin D receptor is apparently a negative regulator of a number of genes, and the loss of its suppressor activity could potentially lead to the activation of those genes, such as the WNT inhibitor known as the secreted frizzle-related protein 1, as well as inhibitors of parathyroid hormone-related protein. This may result in alopecia. Now, vitamin D receptor binding to DNA is critical function of the vitamin D receptor in its regulation of hair cycle. The current understanding that we have is that vitamin D receptor mutation causes defect DNA binding, retinoic acid receptor heterodimerization, or absence of vitamin D receptor may result in alopecia. Another test that we need to do in the vitamins is vitamin B12, which is necessary for DNA synthesis, neurological function, and red blood cell formation. The role of folate and vitamin B12 in nucleic acid production suggests that they might play a role in highly proliferative hair follicle. The next disorder in discussion will be alopecia areata. So alopecia areata is an autoimmune disorder. It is a non-scarring disease in which the exact mechanism that induces loss of immune privilege is unknown. The key characteristics here are that it is a sudden patchy hair loss, often with well-demarcated bald patches. It can be associated with other autoimmune diseases. Lab tests done in alopecia areata are CBC, autoimmune test, thyroid profile, and serum zinc. In CBC, we have to see the abnormal white blood cell counts within a CBC that can suggest inflammatory conditions that may contribute to hair loss, potentially pointing towards autoimmune disorders. The autoimmune tests such as ANA and anti-dsDNA help in identifying any underlying systemic autoimmune diseases such as lupus, which do coexist with alopecia areata. Thyroid function test, the cause of alopecia not being fully understood, but is believed to involve genetic susceptibility, autoimmune processes, and potential stress as contributing factors. Now, alopecia areata patients have had a higher prevalence of autoimmune conditions, including Hashimoto's thyroiditis. Studies have shown that autoimmune thyroid diseases are more common in people with alopecia areata, and they are more likely to have thyroid dysfunction such as subclinical hyperthyroidism or hypothyroidism than other individuals. Certain human leukocyte antigens, specifically HLA-DQB103, are associated both with alopecia areata and antibodies-induced hypothyroidism. Coming to the role of zinc in alopecia areata, so zinc is important for DNA stability and repair, making it essential for normal hair growth. The exact mechanism by which zinc acts in the hair loss is not clarified, although metalloenzymes containing zinc have a potential role in the regulation of hair growth. Zinc fingers are small protein structural motifs for many transcription factors that regulate hair growth via the hedgehog signaling pathway. Zinc is also an essential cofactor for multiple enzymes, and it is involved with important functional activities in the hair follicle. And zinc also being a potent inhibitor of hair follicle regression, and it accelerates the hair follicle recovery. Lastly, we'll be coming to the scalp biopsy, which is usually not done in routine practice, but can be a key tool for confirmation when the clinical picture is unclear. So the biopsy shows lymphocytic infiltration around hair follicles, which is typical of alopecia areata. After discussing the common conditions of non-scarring alopecia, we'll now be evaluating the tests which are helpful in the scarring alopecia. So scarring alopecia, it is the permanent hair loss due to destruction of hair follicles replaced by scar tissue and can occur with conditions such as lichen planopilaris, discoid lupus erythematosus, or folliculitis decalvans, amongst others. Tests done in such conditions are autoimmune test, that is ANA, and anti-dsDNA test, which can help in diagnosing systemic lupus erythematosus, which is a cause of scarring alopecia. Another test that we can do is the scalp biopsy, which is the definitive and confirmatory diagnostic tool, revealing inflammation, fibrosis, and the absence of hair follicles that is indicative of scarring alopecia. Now, culture and PCR can also be done in infection-related scarring alopecia, where we suspect a fungal or bacterial infection. So microbiological testing may help to identify the pathogen like Staph aureus or fungi in cases of tinea capitis. The next entity that we come to is the drug-induced hair loss. So this is the hair loss triggered by medications, particularly chemotherapy, anticoagulants, beta blockers, or anticonvulsants. They can cause both telogen effluvium, that is a diffuse hair shedding, or anagen effluvium, that is the loss of hair during the anagen phase, that is our growth phase. Lab tests done in such conditions are the thyroid function test, which can rule out the thyroid disease that may be contributing to hair loss, especially if a patient is on medication which is known to affect the thyroid function, like lithium. Medical history is very important in such scenarios so that we can discontinue or change the causative drug that is leading to hair loss so we can start seeing the hair growth. Complete blood count is useful in identifying anemia that could exacerbate the drug-induced hair loss. Then we'll be talking about the anagen effluvium. So the key characteristics here are that there's rapid, widespread hair loss due to chemotherapy, radiation, or poisoning. It affects the hair in the anagen phase, which is the growing phase of the hair, leading to hair loss within a few weeks. Lab tests done here are basically for the heavy metals. So in case of poisoning, tests for heavy metals such as lead or mercury is done whenever necessary. Tinea capitis. So this is a fungal infection of the scalp hair. It is caused primarily by dermatophyte species that are the microsporum or trichophyton. The fungi can penetrate the hair follicle's outer root sheet and ultimately may invade the hair shaft. Clinically, tinea capitis can be divided into two parts, inflammatory and non-inflammatory type. So the non-inflammatory type usually will not be complicated by any scarring. But the inflammatory type, as we all know, is the chirion, which is a painful nodule with pus and can lead to scarring alopecia. Tinea capitis, though, occurs in children between the age of 3 to 14 years, but it can be seen in any age group. So in such a condition, the lab tests that are supposed to be done are scalp scraping or culture for the fungal culture to identify the fungal infection. KOH preparation can be done. So the skin scraping can be visualized under the microscope. And PCR testing is done to detect any fungal DNA in the hair follicle or scalp lesion. Coming to the last condition that can contribute to alopecia, that is the PCOS. So the three main features of PCOS are irregular periods, which means your ovaries do not regularly release eggs, excess androgen, high levels of male hormone in your body, which may cause physical signs such as excess facial or body hair, and polycystic ovaries, that is, your ovaries become enlarged and contain many fluid-filled sacs that surround the eggs. The tests that are done in PCOS are hormonal tests, which is the testosterone level, Elevated testosterone level are often seen in PCOS and contribute to hair thinning. DHEAS levels is also an androgen produced by the adrenal glands, and it is elevated in PCOS. Ultrasound can give us a confirmatory diagnosis in cases of ovarian cysts that are associated with PCOS, and it helps confirm the diagnosis of PCOS, which is often associated with female pattern hair loss in women. So the take-home message from today's webinar was to gain an understanding of which test is important, when is the test supposed to be done, and why is it important. So this is a table summarizing all the common forms of alopecia that we see in our day-to-day OPD that comprises of majority of patients in our clinical field. So firstly, talking about the androgenetic alopecia in men, the basic tests that are supposed to be done is testosterone and DHEAS. Genetic testing comes to be an advanced, not routinely practiced, but can be done to see any genetic mutation in androgen receptor. Androgenetic alopecia in women. So iron profile, as we all know, plays an important role to know the ferritin levels. Thyroid profile is supposed to be checked. And apart from that, testosterone and DHEA is supposed to be checked because AGA usually seen in perimenopausal phase of women. So that is why hormones play an important role. Genetic testing has also been advised in AGA for women, but it has not been clarified how much role it plays in women. Telogen effluvium, so the basic tests here are CBC, ferritin, thyroid profile, and amongst the vitamins, the common ones are vitamin D3 and vitamin B12. The advanced testing here are the hormonal profile, which is the testosterone, DHT, DHEAS, and sex hormone binding globulin. Lastly, talking about alopecia areata, CBC, thyroid, and serum zinc come out to be the basic test in such cases. And if we are suspecting any underlying autoimmune disorder or any coexistence with other autoimmune disorders, so autoimmune tests can be carried out along with scalp biopsy whenever the diagnosis is unclear. In the end, I'd just like to highlight the importance of lab diagnosis. It helps to rule out any understanding of the system conditions, to identify the hormonal imbalances, to diagnose the autoimmune conditions, to differentiate between scarring and non-scarring alopecia, to assess the impact of medications, to monitor the nutritional deficiencies, for any genetic testing in cases of hereditary alopecia, and to help us diagnose and evaluate the condition for better understanding and treatment. Thank you.
Thank you, Dr. Amandeep, for such a lovely presentation. I think it was a very lucid presentation and covering all the aspects of hair loss and what all lab diagnosis should be performed for diagnosing those cases. So we have two questions from the audience. Uh, I think you have covered most of them, but let's take up these questions and specifically answer to these particular queries. So Dr. Anjali is asking what basic blood tests should be done for a patient who is a male and he's presenting with a male pattern baldness. So the basic profile that you need to do at the first visit for those patients.
So for the first visit, of course, the hormonal profile can be done. So testosterone is one that we can look for along with the DHT levels. Apart from that, those studies have stated that iron profile is more commonly done in women, but there's no harm doing it in men as well. These are the two basic that I would recommend, the hormonal profile and the iron profile.
All right. Do you do thyroid profile also for these kind of patients? Because thyroid also is a known cause for both male and female pattern hair loss.
So usually I do CBC, iron, and thyroid, three of them. Sometimes I also go with vitamin D3 and B12 because usually in population we do have less levels of vitamin D3 and
Right.
along with the testosterone and DHT. This is the panel that I usually go for in the basic test.
All right. All right. Yeah, makes sense. I think we all are doing these. This is the strategy that we all are following. So the second question is, which test would you like to do? I mean, which are absolutely required for PCOS induced hair loss in females?
So the entire hormonal profile, like your testosterone, DHEAS, your DHT levels, these are the ones that I do for PCOS with an ultrasound, which is the first and foremost. So I would recommend patient to get an ultrasound pelvis firstly to rule out if the patient has any PCOS and then further go with the blood test.
Yeah, I think that is the take home message, that ultrasound usually is the first test that should be done before moving ahead with the hormonal profile. So in cases, Dr. Aman, where you are having a normal ultrasound but still you're suspecting PCOS, do you still go ahead with the blood test, or you don't do that?
So I don't usually go ahead with the blood test, but yes, if the patient is not is giving a history of occurrence of any hair fall or for that matter acne around their periods, I definitely take a second opinion from a gynecologist and would go ahead with the blood test in case the pattern is always a hormonal profile and the patient usually is complaining of hair fall and with the treatment also I'm not getting a great result. But if clinically I'm suspecting, then I will go ahead with the test.
Okay, and if everything is normal, like let's say the PCOS ultrasound profile is also fine, the blood workup is also fine, do you look out for an alternative diagnosis, maybe chronic telogen effluvium cases, or maybe some nutritional deficiencies? And what all blood
Definitely,
tests
sir.
would you like to go ahead
So the
with?
basic profile I will get done. So the CBC or iron profile, thyroid, D3 and B12. This is something that I will get done if I'm not able to come with a conclusion in terms of PCOS. So this is one panel that I usually do get done in women.
All right, thank you for the inputs. I request the audience, if they have any further queries, they can either ask them live or they can put up their questions in the chat box. If anyone of you have any doubts, we can take those doubts live also. You can just speak up your query.
I would like to ask one question. I joined late, sorry, but I
No
wanted to
issues.
know why testosterone and DHEA is done is for every case of androgenic alopecia in male. I joined late. Maybe you must have covered. If you could please repeat it.
Yeah,
Yes,
Dr.
ma'am.
Aman. Yeah.
Actually, testosterone gets converted to DHT, so that's DHES, and we know the literature says that DHT is responsible for miniaturization of hair follicle and reduction of the hair growth. So these are the two things which we can actually go for and test and see if it is the testosterone is the one that is responsible for hair loss.
So
Yeah,
basically,
I
I
think,
had one. Yeah, yeah.
yeah,
You
ma'am,
can go
please,
ahead.
please. I think you wanted to ask whether we should do DHT and testosterone for every case of male pattern
Yes,
baldness.
yes,
Yeah, yeah. So I think, ma'am, not every case of male pattern
in
baldness
male.
will warrant.
Yeah.
Yeah, not every male case will warrant these tests. But yes, patients who are not responding
Yes.
to your conventional therapies like finasteride, minoxidil, you are giving them, and still the patients are experiencing hair loss. There, actually, this concept of doing the testosterone and DHT has come into picture in the last 4 5 years. So I think those are the cases there where it is said that you should go ahead and see the levels of testosterone and DHTs.
So could you tell me the implications also, whether it is DHES is increased, decreased, and do you use it for monitoring also, that once you give finasteride or dutasteride, do you monitor the levels of whether they are reducing?
Yeah, so in my experience, I have encountered a couple of patients where the testosterone and both DHTs are raised above the normal levels. What I usually follow is I take an endocrinologist opinion for that, because I want to see why exactly the hormones are raised in those patients. So usually the first approach for me is to send the patients to an endocrinologist, seek an opinion. There might be a possibility of a tumor which might be leading to the raised levels, or maybe physiologically also some patients have higher levels. So after the opinion, yes, I after the starting of the treatment, I do use these tests once in 3 months to see whether these levels are within the same normal range, or they are still high. So this is what my usual approach is. But as far as the treatment goes, I think from our side, the addition of finasteride is something which I do stress upon after I see a raised testosterone and DHTs and patients who are not responding, because we see patients are very reluctant of taking finasteride at the beginning. So I do stress upon that is one management that changes in cases where I see a raised level of testosterone and DHTs. I do stress upon that the finasteride should be a part and parcel of the treatment.
Yeah. So why this question came up to me is there was a doctor couple and their son had severe androgenic alopecia, and the father also had it, and they were taking treatment from few doctors, and they were not, he was not responding to dutasteride, and he got this testosterone level done, and
Right.
he came to me for an opinion, and I said we generally don't do testosterone levels, and his criteria was reducing because his levels were normal, but still
Mhm.
it should reduce than the normal level or whatever level was the baseline, it should reduce. His funda was that time I actually read few articles and spoke to one or two professors in a medical college, and they said routinely it is not done, and even it doesn't show. I mean, people with severe alopecia or not responding might not have increased DHEAS levels, so it is not a general guideline. That was the question I actually wanted, whether which cases should we do and whether we really see any decrease in the levels after monitoring, after starting with finasteride.
Yeah, ma'am, I think I totally agree with you. Routinely,
Mm.
DHT and testosterone, I also don't do it. But
So
yes, patients who stress upon
yes,
that, let's get it
yes.
done, or where I'm seeing almost no response, because there are patients who don't respond to minoxidil and finasteride also, the topical formulations, dutasteride also. So there I, as a part and parcel of, maybe if I'm not missing anything, to just to make
Mm.
sure, I do get these testosterone and DHT also.
So the take home message will be that when the patient is not responding, or when sometimes the patient insists, then maybe we can get it done. And then
Yeah.
maybe we can do a baseline and then see after the treatment, after 3, 4 months, whether the levels have any change.
Yes, ma'am. This is what I'm following.
Yeah. Yeah. Thank you.
All right, ma'am. Thank you so much. So I think with this, we conclude our webinar for today. I would like to thank Dr. Amandeep Kaur Saluja for enlightening us with the information about the lab test in hair loss patients. And I would also like to thank Swasthderma Labs for organizing this webinar. Of course, we need these kind of webinars more frequently, because there are a lot of literature which suggests that do a particular test, and then clinically we have seen that some of the tests are not required. So we do need to have some consensus about what blood tests should be done in a particular skin or hair disorders. So thank you, Swasthderma Lab. I now hand over the mic to Vikram.
Uh, Thank you all. Thank you for explanation of diagnostic values of blood test. So, uh, our comprehensive packages already includes hormonal, vitamins, autoimmune, hair scraping, culture, and genetic DNA testing, as told by Dr. Amandeep. So, thank you all for your participation.
Thank you.
Thank you.